Hey YouTube, welcome to MedTurf where you get a no-frills discussion on diseases, and today's disease is CMT. Before we talk about the treatment, let's dwell a bit on the pathophysiology. I know there's a lot to read here, but if you can just listen, you could register 80% of what is in here. CMT A1 type is the most common form of this hereditary neuropathy of sensory and motor systems. So you basically get sensory loss and muscle atrophy. Affecting mostly symmetrically distal extremities, it is inherited in an autosomal dominant fashion. CMT1 patients usually present with typical CMT onset within adolescence but remain ambulatory with no reduced life expectancy. They do manifest symptoms of clumsiness, falls, gaits, and foot drop while walking. There is also reduced sensation to all modalities. Muscle stretch reflexes are unobtainable or reduced throughout. CMT1A represents 70% of the cases and is caused by a duplication within the short arm of chromosome 17 from region 1 band 1 subband 2 all the way to region 1 band 2, encoding the gene for peripheral myelin protein 22. Let's just call it PIMP22 or PAMP22. This results in patients having 3 copies of the PIMP22 gene rather than 2. And guess what? This protein accounts for 2 to 5% of the myelin protein and is expressed in compact regions of the peripheral myelin sheath, whereas now you have a lot of this, and that leads to accumulation of the PIMP22 protein. The pathophysiology is complicated, but suffice it to say that PIMP22 is vital for the normal creation and maintenance of the myelin sheath. You make a lot of it and you get onion bulbs on biopsy, and a really bad job in maintaining whatever myelin is out there leads to demyelination on biopsy as well. So it makes sense that it culminates to decreased conductivity in mostly sensory nerves and motor nerves. There is often atrophy of the muscles below the knee, particularly the anterior compartment, leading to the so-called inverted champagne bottle legs. Here circled are peroneus longus and brevis muscles that are innervated by the superficial branch of common peroneal nerve responsible for eversion, and we have the tibialis anterior innervated by the deep branch of the common peroneal nerve for dorsiflexion. So you're about to see foot drop as another symptom as these muscles weaken. One way of diagnosing this is by doing a motor NCVs, which are generally 20 to 25 meter per sec range. Normally it's 50 to 60 meter per sec generally. According to Wikipedia, conduction velocities of more than 41 to 44 meter per sec range are reported in the peroneal nerve. The conduction velocity drops to a merely 20 to 25 meter per second range, which explains a lot about the gait. Nerve biopsies are not performed on patients suspected of having CMT1 because the diagnosis usually can be made by less invasive testing like nerve conduction studies and genetic testing. However, when sural nerve biopsies are taken, they reveal reduced number of myelinated nerve fibers with a predilection for loss of large diameter fibers and Schwann cell proliferation and laying out of abnormal myelin around thinly or demyelinated fibers, forming so-called onion bulbs. These are some large diameter fibers that you ought to know. Certain cardinal symptoms include pescavus, stork legs, hammer toes, spine abnormalities, and even claw hands. CMT often causes contractures, which are stiffened joints due to abnormal tightening of muscles and associated tissues. There's also decreased pain sensation because the spinothalamic tract can be involved. Paresthesias and decreased proprioception because dorsal columns too can be affected. There was a case reported in March of this year about a man in China who was found to have all the same symptoms but with a new insertion mutation. That deserves a whole new video. They found only 6 bases that were inserted into the PIMP, disrupting the alpha helix structure of the PIMP. If you have a life outside of medicine, you probably look at paintings like I do. This is one of Andrew Wyatt's most famous 20th century paintings, Christina's World, featuring a woman dressed in pink lying on a grassy field as she props her body upright to look toward a house in the distance. Turns out a neurologist in Minnesota said it was very likely that this woman, named Anna Christina Olsen, who was Andrew's neighbor at the time, had CMT. According to her medical history, her feet were affected first, such that at age 3, she walked on the outer edges of her soles. She could walk unassisted until she was in her 20s, although she did stumble frequently. It was around that time that her hands showed signs of muscular weakness as well. In her 50s, Olsen was burnt while sleeping near a stove. The fact that she could sleep through this burn implied that she had difficulties with pain sensation making this fit the profile. Moving on to treatment, we can't cure this, but we can manage it by encouraging patients to maintain movement, muscle strength, and flexibility. So basically, physiotherapy. The use of ankle foot orthosis also helps with foot drop and pes cavus and balancing problems. According to this systematic review that reviewed a total of 11 studies about physiotherapy in CMT, concluded that endurance exercise and strength training increased muscle strength and shortened and improved the time taken to execute daily activities. Thank you for watching.